FLSs from a service provider perspective, and I thought, well, this comes just really fitting for me. I'm saying that because I'm a health economist, and one of the things that I've encountered as I've been working on osteoporosis and fracture prevention for a long time is that, to be honest with you, I think the clinical case is made, the patient case is made, and I wonder sometimes when I see the gap in treatment and care whether there is another case to be made, and it's the case for investing in this, for having the services do all they can. So I'll try to give you, I know I'm aware of, what is it that they say, preaching to the converted. We're probably all here convinced that this is a good idea. Fracture prevention is a good idea. Well, as I said, as a health economist, I hopefully will give you another view on this that you can add to your arsenal when making the case for yourselves if you need to make it, and add something to your agenda of work. So let me take you through how I see this and how we've been working on this. So the first thing we all know, that someone with a fracture is, my analogy to this is a ticking bomb, right? Once you have someone with a fracture, that person is very likely to have another fracture, a subsequent fracture, and with those subsequent fractures, what we know is that, well, we spend so many resources, so much of our resources trying to screen people and find those at risk. Well, here we have them. If they had a fracture, they're very likely to have more fractures in the future. We already know who they are and where they are. So we can pick them. The outcomes for them are likely going to be worse. I mean, we're talking about staying in hospital for longer, we're talking about having more complicated surgeries, even mortality is going to be an issue. Now, it so happens that these are preventable. If you know where they are, well, we can probably identify them, assess, treat them, and how we treat them. That's a question for all you clever people and the clinicians and all that, and start closing that gap, right? So from my perspective, every patient that leaves a hospital and hasn't been referred to an FLS or to secondary fracture prevention is a potential problem for themselves, their families, the healthcare system, and that's where the attention can be placed. So for me, this is rather than a clinical issue, this is a service issue. This is what I come to tell you today. Now, in my world of health economics, the sort of things I talk about are cost effectiveness, which you would have heard, I am sure, in the past. And this is the usual pound per, QALYs and pounds, right? So how many pounds per QALYs? And QALYs are the quality adjusted life years. So we're interested in survival and quality of life together. And we're trying to find where is the value of that, because we have not enough resources and funding for everything and all the care we need to provide. So where do we get the best value for our money as a public healthcare system? The FLSs do really well here, and I'll tell you about that in a second. The next thing we talk about, and is important to us, is budget impact. Well, great, maybe the case is made, but we need some funding. Okay, well, how much funding? Where? Where should it go? Where do we need to strengthen? For how long? Well, what does this look like? Those questions I think are really important and are not often made to the detail that we need. And then resources. Well, what resources are needed? Specifically, what are we talking about? The coordinators, the nurses, the assessments, the labs, the DEXA scans, and then being aware of those that were going to be saved. Because all those fractures that are avoided are bed days that are not going to be used, consultations that won't be needed, surgeries that won't happen. So there is a savings there, and we want to keep track of that to make our case. So if I were to offer you a very quick snapshot of FLSs and cost effectiveness, I just picked 4 or 5 studies that have been published in different years, different countries, different approaches, and they all found FLSs to be cost effective. The last one is a systematic review, so it looked at many of them. Right? Now, And even in that review, they found some that were not only cost effective, which is what you invest, you get a lot of benefit from that, right? Some of them were cost saving, so you get the benefit and you save costs. And those are rare, right? We don't find those often, but in some cases, in some circumstances, it can be, FLSs can be cost saving. But they're definitely cost effective, I would say, everywhere, in different ways and different levels, right? So what they did, though, to show that is that they use modeling, and that's part of what I do. We use mathematical models to try, because we don't do experiments, do we, with FLSs, so we try to understand this with epidemiology, and in my case, with health economic models. And what we did is that, well, let's try to go very detailed on these models, and we went for a model that was a simulation of a patient, one patient at a time, hundreds of thousands of times, and follow the pathway and see what may happen to them, what the risk it is that they face of a fracture after they've had a fracture. If it was hip, what is the risk that they have a spine fracture, or a non-hip, no-spine fracture? And if they get medication, which medication do they get? So we model this in a different way, very carefully at patient level, with monthly cycles so that we know what happens at each month. We looked at data from each of the countries where we tried this model, where we tested it. We looked at their own data instead of taking data from my country and plugging it into another, because all countries operate differently, don't they? And we looked at that pathway to understand, well, which medications do they get? How do they identify people? Do they assess them? How much does that cost? So that we get a picture in each of the countries, right? And we added social care, because often social care, we talk about healthcare often, most of the time that's what we're here to do. But social care, it's often a bigger source of funding that gets affected by what the fractures are and mean. So by doing this modeling, we're able to see quality of life that is gained by preventing fractures. But specifically then, we can count, we can estimate the number of bed days that might be avoided, the surgeries that can be avoided, those outpatient consultations, and the budget impact in the end, considering what we need to invest and what we're going to save by having fractures that won't happen if we prevent them, right? So we did this in many countries. You can see the list in there. And what's common about them is that it was cost effective in all of them, as I've said. So some investment was necessary, but it was worth the investment. The value for that investment made it worthwhile. Bed days were reduced at different levels because the countries were different. They treated patients differently. The pathway was different, but they all reduced their bed days, their surgeries, and the funding needed was partially offset by the savings they've done. So you would expect that. For each country, we were able to see what you see in this case for Switzerland, right? We modeled these two worlds, one where there's no FLSs, or whatever they have in their country at their own, at the time. Some level of identification, some level of treatment, with some sort of medication, and some level of monitoring. And then we compare that against what it can be, right? We invite you to think about what else could be in terms of identification and treatment and monitoring. And then based on that, we said, well, how is the comparison within those two worlds in terms of benefits for patients, in terms of the implications on the staff and the resources needed, and then the number of fractures that will be avoided. And from there, we can estimate then the number of bed days that can be saved and the benefits to social care and the quality of life, like I said, and the consultations. Well, it's a very detailed example. I've extracted so that you can not think about the different countries and the different sizes, and per 1,000 people with an index fracture, you can see that in all cases you can get an important number that varies between 100 and 400 bed days that can be avoided only over 5 years. Right? This is a 5-year model. And surgeries for each 1,000 people with an index fracture, we're talking about anywhere between 10 and 40. Now, why is it different? Different countries, again, again, different treatment pathways, different choices along the way, and clinics the same, and rehabilitation days, and so forth. So, great savings, great impact from a service provider point of view. The benefits are realized in all jurisdictions. It depends on how things are done and how they can be done. One powerful message that I found that we can produce when we do this is that we can put together, as we did in this case for Switzerland, the impact of the investment that is needed in the first year, minus the benefits of that. Well, in the first year you need to invest a lot. No surprise to anybody, right? And the benefits are not so great because the fracture prevention happens over time. People need to be adherent on medication for long enough to see the benefit. Well, here is the picture for that. Second year, you start to see that net investment being reduced because they still need to invest, but the benefits start to creep in. So the net investment is coming down. By the fourth year, it's already cost saving on a yearly basis. It was already cost saving. And then the fifth, and so on, if we were to extrapolate this over time. The message here, yes, you do need investment, but the message here, this is a long-term issue. The view has to be long-term. The benefits come long-term. You have to be willing to invest to begin with. And it makes sense. You need the staff, you need the team. You need medications, you need the assessment. Fractures are prevented along the way, and the one that I didn't add here was it would be a third axis, it would be quality of life. But that one is beautiful, because each fracture that is avoided, once a fracture is avoided, there's a benefit of quality of life of that year, compared to what it would have been if they had a fracture, but that benefit stays the next year, and the next, and the next, and the next. Because if my fracture was avoided today, there was a benefit to me every single year of my life thereafter. So the benefit of that compounds positively. So, as I close here, one key thing that we want to keep in mind as we understand this model is that one of the main drivers is identification. And I think we'll talk more about identification in one of the talks after me. But that is a driver that is in your hands to some extent. If you're providing services and can identify people, those ticking bombs, then adherence to treatment, which treatment are given, and how we can help people to stay on treatment for long enough so that the benefit is accrued. That pharmacological practice is part of what this decision about, they go hand in hand with adherence, but thinking about which patient, what level of risk, which fracture site, which medication, they all play a role in the costing and the benefits of this. And if I could invite you to keep track of something is on data collection. We need to understand, and this is one of the things we couldn't find in many countries, a clear understanding of the fracture risk, of the subsequent fracture risk. They didn't collect data about what happens to people over time when they had a hip fracture and what they were treated with and how likely they were to have another fracture. That data was lacking. My invitation to you, as much as you can, collect this data. We needed to be able to model these things and give you the information you need to make decisions. It is critical. We do the best we can with the data that we have, and there is some data out there where we can do better. So for me, the investment case, if it boils down to one thing in terms of resources is, well, we want to be aware of and keep an eye on the resources that are needed, and you know them well. Your coordinators and your clinical staff and your assessment and your labs and everything you need to provide the service, and do keep in mind all the benefits, because we seem to lose track of them, the benefits. By avoiding fractures, we're gaining on not having all those bed days in hospitals, and we know how badly we need those beds available. Well, we can. Low-hanging fruit, if you ask me. We could have that available to us, as it is with the social care and outpatient and emergency department. So as I close this, I think the evidence is sending a clear message. just committing to an FLS as part of your standard care makes sense not only from the patient perspective and the clinical perspective, from the service perspective and the National Health Service perspective. It makes sense. It is good investment. It is value for money. Identification is worth investing in. Connecting your local data, please, as much as you can, and think long term. It needs to be long term. Yes, we need to have an investment that you've probably already made in Wales to a large extent to begin with. We'll keep it going. And I want to thank you, closing this with the message that the evidence is there, it is clear, and the investment case for me is robust. Now it's all for you to keep doing what you're doing and fine-tuning where you can, because it could be even better and more efficient for the providers, which means for the patients and the healthcare service. Thank you.